Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Good afternoon, Turds. Welcome back to a super exciting episode that we're going to do for a diagnosis that I think impacts all of us and that we're seeing in private practice. But personally, I don't think I ever heard of it before 5 to 7 years ago.
Yeah, I don't think we learned about it in school at all, right?
I don't think we did either.
Yeah.
And so this is a new phenomenon. We're going to dive into eosinophilic esophagitis, which is something.
Mouthful.
It is a
Can
mouthful.
you say it 3 times
I'm a
fast?
good speller, and I struggle sometimes typing it into Google. I've got it down now.
By Google, you mean up to date, right? Up to date.
Either or. Depends what I'm looking for.
Definitely not ChatGPT.
Right.
So Dr. Kapadia is going to dive in and give us a good deep dive on EOE.
Okay, sounds good. So, so this is basically, I'm going to kind of ask you guys some questions just to get a sense, basically quizzing you on what you know.
Oh, I love this game.
And so this is like a loaded question, but what do you think is the end result trigger for EOE? Not all the underlying stimuli and such, but the end result trigger. Do you know?
That you have eosinophils over a certain amount of high-powered fields in an endoscopy?
So that's part of the definition, but what triggers the symptoms in people?
Histamine.
So it's kind of you have to kind of read my mind here.
It's not
What I'm
we're failing.
going for.
Quite that close,
What I'm
yeah.
going for is this is a known recognized allergen-mediated disease.
Oh.
Are you aware of that? Because I was not fully aware of that. That
It's
it
completely allergen mediated.
it is mediated by food allergies. It is like well accepted that the end result. I mean, there's all these things we're going to talk about, but food allergy is a known end result trigger for the symptoms.
Or sensitivity.
Okay, so this they generally call it allergy.
Okay.
That being said, that's a really good question because we'll get to the fact that there's not any great tests for it, but we do run across that with many allergic triggers.
Right.
And the interesting part also is that there's some seasonal variation in disease, and so they've also recognized aeroallergens or respiratory allergens as potential triggers for symptoms.
So let me start from the beginning. As clinicians, what are we going to see? What's going to make us even think that this is a potential diagnosis?
Well, that was my next quiz question.
Okay, great.
So, what symptoms would someone present with that would make you think this may be EOE?
Heartburn.
That would be my first thought. Heartburn is my first thought.
That's a good thought. It's not the correct answer.
Oh,
What?
But
okay.
Is that the main symptoms?
So dysphagia and food impaction is actually
Food impaction.
and dysphagia.
Oh, okay.
In adults and teens are the most common symptoms.
Can I bring in a patient case just so you guys can track when I was seeing this? Like the first patient I ever saw with EOE.
You're throwing me off my outline.
I know, but I'm trying to keep it engaging.
Go
too.
ahead. I want to mention once you're done that kids present with different symptoms that we'll talk about.
I want to hear those.
Do kids exist? Is that a thing?
For some of us, they do.
Okay. So I had this patient come in and she had this diagnosis. She came to me with a diagnosis and her gastroenterologist, she basically could not swallow food. Things would get caught in her esophagus all of the time. And it was so uncomfortable. And they put her on a crazy 5-food diet. The gastro
We
did
will
this.
talk about
Okay.
the 5-fed diet.
Okay, great. Okay. So the number one
And the 6, the 4, the 3, the 2, and the 1 fed.
Oh, wow. Okay.
Okay.
So we're
not as bad as you think.
we're looking for basically what's going to trigger our brain is somebody where food gets caught in their esophagus.
Is it because of spasms?
No, but the main presenting symptom in adults is this food impaction dysphagia? And the physiology we'll talk more about.
Okay.
It's not, there can be strictures.
Yeah.
Can be an end result of this condition being
Because of the
untreated for too
inflammation?
long. And then the stricture can cause a physical impaction.
Wow.
Yeah, I don't know if there's any correlation with this, but a lot of my folks with like histamine gut issues in general, I'm
sure there is.
more likely to struggle with pills.
Right.
Yep.
Totally.
Yeah, and
Yes.
they may have a component of EOE that hasn't been diagnosed yet,
Totally.
you know?
Interesting.
Bummer. Also bummer.
Right. Now, in children, reflux is a common presenting symptom, as well as vomiting, feeding difficulties, and abdominal
This
pain.
is babies, right? You're talking about babies? Or
This was in children up until teens. They separated it into teens and adults, kind of dysphagia, food impaction. Younger children,
Kids
GERD,
vomit
abdominal
all
pain,
the
vomiting.
time.
Right. So
that's something you don't know until you have a kid. Yeah.
I think obviously,
I remember it as a kid. I was like, kids just puke all the time in school.
Because they're so
I remember
sore.
that.
They're
I'm studying.
Yeah, I think I
didn't have
they're
time to
so
focus on
soric, you know,
that.
like in homeopathy, we think about this miasm or type where they just are so good at like expelling the stuff that's bad for them, and then they're done.
I mean, we kind
that'd
of
be
lost
nice.
it as
Yeah.
adults. It's
Yeah.
not I
That's
hate
what gives
vomiting.
us chronic disease.
Yeah.
Okay, so go on.
All right. So, other symptoms in adults, you can present with reflux, upper abdominal pain. So some of the things you guys mentioned. And so this is really important, what we were talking about with strictures. If there is a significant delay in diagnosis and or treatment, and there's just this uncontrolled inflammation, you can get stenotic lesions and esophageal narrowing strictures, where you do need dilation procedures that, you know, may or may not be
comfortable,
efficacious long term.
Efficacious.
So you don't want to let this go on for super long without treating it.
I do feel like any patient that I've ever had that ever needed a dilation needed a second dilation.
I think so, but I wonder also because we didn't always know the triggers for this, and so if we're like treating the triggers as well, maybe they wouldn't need as recurrent dilations, or maybe there is some permanent changes with the fibrostenotic lesions and tissue where it ends up being a recurrent issue.
And so let's treating the underlying cause, like that's what you're saying, treating the causative agent of this.
Yeah, we're going to talk about that. You're jumping ahead in my outline again. So
keep it together, Ilana.
I know this is my problem. I get very excited.
Okay. So now risk factors. These are the typical things we think about for most of the GI issues we treat people for. So concurrent allergies, but even deeper than that would be the typical antibiotics. Bottle feeding. You know, they potentially
formula
those
feeding or bottle feeding.
Okay, I didn't mean bottle feeding.
Okay.
I'm obviously don't have children. I mean so breastfeeding can be protective.
Because of microbiome stuff,
Probably.
And so all of these things are just, you're messing with the microbiome in the esophagus and you're shunting to a Th2.
Probably.
It sounds, I mean, I'm seeing some similarities with Crohn's.
That's where my thought went too.
Totally. So I imagine a lot of the risk factors for that would apply here, because is there immune modulation?
Well, there's some potential for, is there genetic variations in intestinal permeability, barrier function and such that's a part of this. They haven't proven that yet, but that's, I think maybe some of the drug development might be targeting some of that.
So I am in the process right now of rewriting for a conference one of my old IBD talks. And so just Friday, I did a deep dive into cytokines and
Friday
IBD.
night.
Well, listen, guys.
8 p.m. Friday night.
This is my idea of a fun night. But I started looking at cytokine transitions, where you're transitioning, basically the way cytokines are like hormones where the body uses to communicate with each other, and that you're transitioning.
I'm sorry, I just have to mention we were watching Endless Summer, which is a like 1980s surfing movie.
On Friday night.
Go ahead.
Well, I was doing my IBD talk.
I
think you were having more fun. I'm not sure about that.
It's a good movie.
I was jet lagged.
But there is, yeah.
Go ahead on.
In France time. It sounds rough for you. I have empathy.
It was really hard.
I mean, I'm going to say right now, everybody's life seems better than mine.
Well,
just saying.
It is also waking up at 3:30.
Oh, yeah.
Like every day. So.
I've been sleeping. I took myself off caffeine. I'm sleeping even deeper than my normal.
I am actively
We can
drinking.
talk about it later.
I got a dog, and at 3 a.m, he's usually pooping in my basement. Yeah, that's right.
Disgusting.
That is disgusting. I agree. Okay, so, but what happens with that transition of the immune system is the hormones that are used to communicate, or the cytokines that are used to communicate, move to making all of these pro-inflammatory, pro-allergic conversations. That's probably exactly what's happening here.
Probably.
Everything's cytokines.
It all gets back. And now I can define what a cytokine is.
Nice.
Thank you.
Nice.
Yes.
Do you want to go ahead and Did you already share that?
No, I mean, cytokines are basically proteins that the body uses to communicate different actions and activity.
And they can be inflammatory or anti-inflammatory.
They can be inflammatory, anti-inflammatory. They can go down a bunch of different pathways. There's 5 different branches of them. It's amazing, blah, blah, blah.
So the other thing I didn't know, even though when I think back, this was the case, it's more common in males, in adults and kids.
Interesting.
Which I didn't know. And then we talked about, you want to think about this if someone has an allergic predisposition,
right?
Whether it's food allergies, atopy, environmental allergies, asthma, atopic dermatitis, they're at increased risk of having this other concurrent allergic related phenomenon.
Just on the other side of that, I would also say if you have patients who are diagnosed with EOE, you should be thinking that maybe they have more of a mast cell stimulation, which I kind of had missed up until very recently.
Right. And we'll talk about what the treatments that we use. And then, like you guys mentioned, there is an association between IBD as well as celiac, chronic rhinosinusitis, and connective tissue disorders. And it is a Th2 mediated inflammatory condition.
Should we define Th2?
It's just typically where you move towards having more allergic conditions and you're not as good at Th1 attacking microbes as well, certain types of microbes as well.
Which further shoots you in the foot, because I imagine dysbiosis worsens EOE.
Exactly.
It's like a vicious cycle. So you have to try to get the person's immune system to shift back to Th1 balance somehow.
Or Th3 balance, really.
Oh, God.
Which is oral tolerance.
Oh, I don't think I know much about Th3.
Oh, okay, yeah. Yeah, we definitely need to talk about Th3. And then if we're talking, we should talk about Th17 while we're at it.
Sounds like a nice Friday night.
Friday night. That I might say for Saturday night.
Sounds like a Saturday activity.
All right. So diagnosis. Ilana mentioned this somewhat, but basically, right, endoscopy findings.
That's the only way, right?
A certain number. You have to have more than 15 eosinophils per high power field. That along with obviously the clinical symptoms, or you wouldn't be checking for this anyway.
With biopsy of the esophagus.
Yes.
Have you found that they're doing that?
Yeah, actually, well, I think so. If it's not just because typically
not for a screening, but
you would never do an endoscopy for a screening, though.
I mean, unless I guess if they had a GI bleed, I don't know if they'd be taking EOE samples for someone who they're scoping for a GI.
So
bleed,
probably most of the endoscopies that I'm looking at are celiac. And I don't always see it in there, which is sort of why I'm asking. I see more small bowel.
I don't know if they automatically do it if someone's not having dysphagia, GERD, food impaction. So it's a good question, and I guess it might be good to specify if you want that to be done.
Yeah, well, what you just said, being there's a crossover with celiac disease.
Yes.
I don't know why they don't. It's so easy to just take a bunch of biopsies.
It does take time.
I mean, I've never done it.
Yeah.
So I don't know.
I mean, my thing is, taking a
2 to 4 biopsies is what they recommend from the distal esophagus,
which I'm sure
2 to 4 from the mid to proximal.
I mean, it's the same with celiac. No one takes as many as you should.
It's the same with every condition of the GI.
Yeah.
I do think it takes time. I do think it's more. There's more room for error. Every biopsy can get messed up.
Yep.
So, and I think there's risk. Like it's not just we're fine. You know,
have a perforation,
right.
I guess.
Yeah.
Right. So, and then this is a good tip, actually. We know it takes quite some time to get in for an EGD these days. Maybe we should start doing them. Probably not. I think if you're good at video games, you're supposed to be good at doing endoscopies.
I am aggressively not interested.
I'm not either. You don't want me.
The tools are kind of cool. When the last time I went to DDW, they had all those like expos with the tools.
Oh, really?
Really neat. Yeah, they're like mechanical snakes.
My spatial orientation is so bad. Even I feel like I'd be going the wrong way with the controllers.
I feel like it's borderline, almost not safe not to let me drive.
I know.
You definitely should not let me into your esophagus or your rectum while we're at it.
Well, you can do some minimal rectal examination. Okay, moving on. So barium swallow is a great thing. If someone is having food impaction,
right?
Swallowing issues while you're waiting for the EGD, a barium study could be helpful just to evaluate their swallow function and look for these strictures. So typically what we're doing is I order both now at the same time. They see the speech pathology person, they get a swallowing study, we'll at least know if they have a stricture or something, or if they have another motility issue. And then, by the time then they get in for the EGD at some point.
Cool.
So, okay. And then, you could do this. I don't do this, but like 50% or so of those with EOE will have an elevated serum IgE level.
I'm not sure that has held water for me, but
yeah. And eosinophilia. that's mild but elevated.
Yeah.
So I
There's
don't
so many
routinely
things that cause
right.
it.
So I
Like, what do
don't
we think? Like 5 to 10% eosinophils? Is that a mild elevation? Do
I
we
know
know?
I don't have a definition for that. I guess if you were just going to be ordering labs anywhere and you're like, I think this person might have EOE, if you want to throw in a total IgE and get a CBC with diff to to see the eosinophils also.
And then can we go back to biopsy? The biopsy for EOE, that's a specific CD117 stain, or no?
I feel like you're talking about what the mast cell
Yeah,
people want.
You're right.
Usually.
And so I think that they can see the eosinophils even without that stain.
I have not done the staining, and I'm not sure what stains they need to look for eosinophils. All I know is that the definition is more than or equal to 15 per high
Okay.
power field.
Do you feel this is on the radar of most gastroenterologists now?
Yeah.
I think so.
Do you think it's newer?
Yes.
Yeah.
The last handful of years, it seems to be
that's what
newer.
it seems like to me too.
Yeah, I was actually on a call with two of the gastros that are putting down putting out the first ever consensus statement on EOE,
Oh,
and that was a couple of years ago.
Was that also on a Friday night?
That might have been on a Saturday night because I like to spread out my.
Oh, this was for that thing.
Yeah.
I have a deep love for consensus statements, though. Like, they bring me so much joy.
That's right.
Yeah, I really.
And yet I'm the one who's getting made fun of.
The IBS ones, I'm just like so jazzed when they come out. We know it, like we know it, but it's always like they finally figured out peppermint oil, or like this stuff that it's just validating.
Yes, that's true.
And it makes me feel like people might get better care. But anyway, that's my nerding out.
Yeah.
Yes.
Okay, so it is recommended to have. Well, here's the thing. It's recommended to think about allergies as a trigger. Whether or not you should do testing for allergies is a whole nother issue.
So we're talking about IgE skin allergies, blood allergies.
Here's the thing. So there was a meta-analysis of all of these different forms of allergy testing, and none of them were found to correlate with the foods that cause the symptoms in EOE. Now, traditionally, some GI doctors had people do certain food eliminations and then did a scope after each one, which I doubt any of them have time to do, and no one wants to do that anyway, right? So we're going to talk about other things you can do.
That's great for research.
Was there any data on elimination, though?
Yes. So elemental diet has 91% efficacy.
Shut up.
But I don't know if this is the elemental diet you guys use.
Well,
this
it
is
doesn't
what
matter.
They used back in the day for IBD.
It's an elemental diet.
Yeah, it's an elemental diet. So we know there's a food allergy component, right?
Okay, so let's just quickly define what an elemental diet is. An elemental diet is a powder where like 95% of
Tastes
it
like crap.
Like vomit in your mouth on a good day, or pina colada if you get some new ones.
There's some better ones, but go ahead.
But basically, it is it gives you all of your nutritional needs, and it is absorbed by the small intestine within the first 3 feet of small intestine. So it actually is true digestive rest,
but not for the esophagus though, which is interesting. You're gonna have exposure, but I guess it's such broken down. I think they use like Nutramigen and stuff like that type of amino acid, right? Elemental formula, like what we've used in kids.
Yeah.
And I think it's been used in IBD too.
Oh yeah, it's very effective, but it's borderline torture for IBD. Mainly Crohn's, not UC.
Okay. And so we know there's this component of food allergy trigger. Elemental diet is quite difficult, not really sustainable long term. Allergy testing is so.
Do you know how long people had to be on the elemental?
I don't.
Okay.
For IBD, it's 4 weeks.
Yeah,
it's probably similar.
And SIBO, we're doing like 2 to 3.
SIBO, we're doing 2 weeks. And I do think that I personally have had patients who 4 weeks was not enough for severe IBD.
I feel like it would take less time for this because it's like direct contact with the esophagus that's causing the problem. But I don't know that.
I guess my thought is because it's not digestive rest for the esophagus. My thought is the reason it's working is because you're taking the inflammatory
proteins out.
Well, it's also so much sugar.
No. I think the reason.
I feel like there's ones that aren't, Rebecca, but not like the stuff we're using for.
But does anyone take those?
Probably
yes.
Not. In studies.
Yes. More people take them in the normal world than that take the ones that we're using.
The sugary ones.
Yeah. Okay. So I think the reason why it's working is not because it's giving the esophagus rest, but because you're giving the whole rest of the body rest. And that's just decreasing the amount of A, eosinophilia, and B, cytokine
like
inflammatory
load.
Could be.
That would be my guess.
It won't hurt.
It's definitely not. I mean, it's hurting. It
hurts like
psychologically.
torture.
Yeah. It's very painful psychologically.
So what most people do, okay, so in our world, I used to do quite a bit of IgG testing, which was part of the study, one of the ones they examined in the study that did not correlate. That being said, I clinically did find it useful for whatever that's worth. And we'll talk about dairy, which showed up a lot on those IgG tests and is a common food trigger for EOE.
Do you think it's because, like people just cleaned up their diet? Like they got some data that encouraged them to clean up their diet?
For whatever reason, what showed up on the IgG food test commonly, like dairy and egg, are common food triggers for EOE.
Yeah.
So I don't know. I mean, I can't prove it, but I did find the test to be somewhat helpful.
Yeah, I see egg on almost all of them.
I wonder if because of my own bias, I underuse elemental diet.
I mean, most people don't want to do it, and I don't know that you need to do it for this condition.
Well,
at least.
Right, I hear you. I will say I have some patients where it has been like the thing that moves the needle. Just
a reset.
Yeah, like I had a severe celiac patient and moved the needle. I think I underuse it. I think it's not because it's so hard for me.
But they're also, though, I feel like the ones we have access to are full of sugar and stuff, right? So there's not like a super healthy elemental diet.
Yeah.
It would be the old lamb and rice, which is not super appetizing.
Okay, keep going. What's next?
So what most people do is an empiric elimination diet. And so you'll see these acronyms for 1-fed, 2-fed, 4-fed, and 6-fed. It's like 1 food elimination diet up to 6 food elimination diet. That's not what you're eating. That's the number of foods you remove.
Okay. That's a little bit more doable.
Yeah. So I think that's a very reasonable approach. We'll go through the foods. Dairy is a trigger for up to 30% of people, whether it's the only food or if it's multiple foods. And so I think it seems silly to not try a dairy-free diet for someone with EOE.
And that's butter too.
That's all dairy.
That's all dairy.
Yeah. So if you were going to do a 1 food elimination, I would definitely do dairy. I've kind of given people the choice. You can start with 1 food elimination, work your way up to 6, or vice versa.
Just knowing it's going to take longer.
Right. So if you do the 6 food, it's dairy, egg, wheat, soy, nuts, and seafood.
Okay, wait. Dairy, egg, wheat, soy, nuts, seafood.
Not corn.
It's not in the
interesting.
Not in this. Yeah, not in this general research area.
And 4 weeks, and then reintroduce.
I think 4 weeks is a good. I don't know that there was exact consensus on how long to do it, but typically with elimination diets, the old way to do it is 4 weeks. So I think that would be reasonable. So again, typically I would either do a trial off of all dairy to start, and see if you get clinical efficacy for about a third of people. A small study that was done, about a third of people had 1 trigger, about a third had like 2, about a third had multiple. So
wow,
you just kind of hope you're not in that third.
And this is just your place. If they are motivated to change their diet, this is where you would start.
This is where I would start. I mean, we'll talk about the pharmaceuticals you can use, but especially if it's like 1 food, to control the disease by avoiding 1 food is usually not a huge deal.
It would be for me, but you didn't find any difference between like cow, dairy, sheep, goat?
It's a good question. I mean,
or fermented.
In the trials, they recommend removing all mammalian milk initially. But
that's my jam.
I mean,
you also don't have EOE.
Not yet.
Personally, if I drink milk, I get an immediate sore throat, and I probably would develop EOE. But I can do like yogurt and cheese and stuff, right? So it kind of depends on the person. But initially, you'd want to remove all of it.
Yep.
And then
I just had a patient come in who was so bloated, diarrhea, distension, miserable, truly miserable. And she cut out dairy and like 98% of her symptoms resolved.
I had a colleague who had UC and it was all from dairy. She removed dairy and she no longer had UC.
It is an interesting, and I'm not saying that dairy is the thing, right, even though it might be a big thing. But for some people, like I'm like you, I can eat all of the dairy and have no issue.
Can you drink milk?
I can drink milk. Like I just had like a steamer. I was at my girlfriend's. She made me.
I feel like I'm gonna die if I drink like milk.
Huh.
Like I feel like I have strep throat.
That seems terrible.
Don't you think there's also a component to like
you think it's all psychological?
I mean, definitely. Maybe.
This was goat milk, Rebecca. Like good quality, that good creamy.
I think you're a little
good
sensitive.
Quality.
You think I'm sensitive
to goat milk? But I can do cheese and stuff. It's just crazy how different the proteins are.
Yeah,
I mean, you might be right. The U.S. food system is not awesome, so you might be right. Also, I just think it might be some people don't tolerate it.
For sure.
When I looked, it was about a third of the population.
And we know that like allergies,
right?
Adults and kids with allergies, if they're severe, try cutting out dairy.
Right, dairy's like the worst.
I mean, and kids with blood in their stool is dairy.
Yeah.
Right? That's the first thing we do is we take them off of dairy.
Poor kiddos.
And so, I don't think I don't think that's a rule for everybody.
No, it's
like not. I can't eat a drop of gluten or I get wicked constipation and terrible gas. but I can have all the dairy in the world. I can eat exclusively dairy. I wouldn't. Really, not for too long, at least.
Yeah, everyone's different. So that's kind of how, you have to talk to the patient. Do you want to start with one food? Do you want to just take them all 6 out and see how you do? If you take all 6 out, you can just gradually add them back in, right? And then it can kind of, I feel like it's a more comprehensive.
I will say, when you're adding them back in, slow is the name of that game. Don't do it too
Maybe
fast.
once a week.
One food a week. Yep.
Yeah. Okay, and then we talked about the study that showed all of these other forms of allergy testing: serum IgG, serum IgE, skin prick, skin patch, basophil activation. None of them were shown to correlate in this study.
So what about testing for respiratory allergens?
I mean, that's interesting because it can cross-react, and I did frequently in private practice send people to the allergist to get skin testing, and it can cross-react with food allergies. So I think it's not a bad idea. But it might be easier to just start with the food elimination, see if you can get a simplified approach. If someone's very reactive and you're losing a bunch of foods, I think then it makes more sense to send them to the allergist and see if you can get the cross-reactivity down.
And why would you do the skin prick over like the region panels?
The skin prick is supposed to be more accurate than IgE panels.
So when I've
IgE blood.
Right.
IgE blood. The skin prick, the topical skin prick, is more accurate than IgE.
Intradermal testing by an allergist is more accurate than...
When I've talked with allergists, they've told me that there's like a lack of standardization on what the skin prick formulations even are.
Probably.
So is it like solidly reproducible is my question.
That is a damn good question.
I think most of them use a couple companies for the antigens for aeroallergens. And the intradermal testing for that is supposed to be pretty good.
Okay.
Food testing is all
allergies?
like environmental
allergies
in the air.
Okay.
I don't know.
Like aerosol.
Okay, got it. That's not a word that I've heard.
Yeah.
So
I think that could be worth it if someone's very reactive, because then if they get allergy shots or sublingual immunotherapy, it could decrease their...
Does that help?
Probably not sublingual for someone with EOE.
Shots?
Allergy shots could help with the aeroallergens, and there might be some cross-reactivity, or that could be a big trigger for some people.
Right.
So.
Right.
So usually I would start with food elimination, maybe refer them to an allergist. What else? And if you're lucky, it's just one food, which it is for 1/3 of people, according to this study.
Not bad stats.
Yeah, I mean, totally worth it.
The other parts of treatment, so they talk about diet, dilation, and drugs. So we talked about diet. EGD, if they have a stricture, they usually need dilation. And then drugs, typically in the regular medical world.
Can I guess?
Go ahead.
Cromolyn.
No, not in the regular medical. What do we give everyone in the regular medical world?
PPIs.
Yes.
PPIs.
And what else do we give everyone in the medical world? For any inflammatory condition.
Steroids.
Yes.
Yeah. That's obviously.
So we don't use Pepsid.
Not in the regular
we'll talk
world.
about that. So standard is a PPI trial for 8 to 12 weeks, or topical glucocorticoids, budesonide oral suspension.
Does the PPI, are you dependent on it from there on out?
And it doesn't work a good amount of the time.
You don't say.
Histological response 20 to 80%.
Okay, yep, that's
clinical response 13 to 60%.
Wait, so 20 to 80% histological? That's a huge effing difference.
I know.
And then
13 to 60 clinical response.
13 to 60. That's
because
not even that
not
good.
an acid condition.
Right.
Exactly.
Right.
And is there rebound after stopping?
Usually.
Always.
Right?
Why are we giving this?
Because you have to try it.
Well, I think what most people start with topical glucocorticoids, budesonide, which is supposed to not have as systemic effects.
15% of it goes systemic, just so we're on the same page.
Okay.
Yeah. So even with budesonide, which is a larger localized steroid, you are still getting some systemic activity, just not nearly as much.
2 milligrams BID for 12 weeks is the initial trial that you're supposed to do if you're going to do budesonide. So now, if someone worsens while they're on budesonide, what do we give people with oral steroids?
Antifungals.
We give them esophageal candidiasis.
Oh, yeah.
So if they develop pain...
Sorry, I thought you said what drug.
I know. You're on the right track. You had to read my mind again. So if they have worsening dysphagia while you're treating them with budesonide...
Why wouldn't we just give them nystatin?
Because that would make too much sense.
Well, no.
And it could lead to resistance. And not everyone needs it.
How about herbs?
Okay, we're not there yet. This is standard of care. We don't believe in natural medicine on this podcast.
Not yet. We're getting to it.
Only pharmaceuticals.
What were you going to say?
I was going to say it makes sense that we don't start them with antifungals because it's not a clear initially antifungal issue, right?
But if we're giving them budesonide,
it will absolutely be. I'd say.
Do you give people antifungals if you're giving them budesonide?
Not if I'm doing a 3-month course. Not if I'm doing a
for
3-month course.
microscopic colitis?
Not if I'm doing a 3-month course.
Is there an association with? Well, we don't know because we don't test lower GI tract for fungus.
It's very, very difficult to find it, but I can assume we can extrapolate based on what we know from steroids that yes, that's going to make things worse. And you're absolutely right. I'm like, maybe it should be in my standard of care.
What if they're on biologics too?
I know we don't do it.
Okay, so finish the question. I don't understand the question.
If they're immunosuppressed, you still wouldn't consider.
I mean, I think it's really good. I didn't think about it until literally just this moment.
The thing is, there's some people you can give them like 5 gajillion rounds of antibiotics and they never get a candidal infection.
Yeah.
There's like some genetic link, and then there's other people you give them 1 round.
Yeah.
And they're
but that second group is 70% of the population. 70% of the population had at one point developed some kind of fungal overgrowth.
That's you were talking about. Oh, okay.
Yeah,
like I got my groups confused. Sorry, what I just mentioned.
Women,
they develop a problem.
Yeah, women in the vaginas.
I mean, maybe not nystatin for all the reasons you just
maybe
said.
Herbs.
Why not?
Because every time, so nystatin is by no means the most effective, but it is the safest. Yeah. After that, you're looking at hepatic risk, and then you're looking at cardiovascular risk,
and resistance.
Right, not with the herbs.
Or even bare minimum low sugar diet.
Okay, that's a great. I love that
idea.
Be
all of us all the time.
It should be all of us all the time. It was not me when I was eating my cupcake for my kid's birthday party.
I my decaf latte, and I did not ask for it this morning.
But didn't it taste delicious?
Slightly, but I can't enjoy it, Ilana.
Right, because you feel the guilt.
Yeah,
that's a true naturopathic perspective. Good job. Okay, so drugs. You start with PPIs. You start with local steroids. That's all they say.
Usually one or the other.
I'm confused about Pepsid.
Okay, so now let's talk about our the standard of care.
Okay,
sorry. Standard of care. They said uncommonly you can use mast cell stabilizers. Now, in our approach, I would start with cromolyn and or ketotifen, H1 and H2 blockers.
Yep.
Okay, so can we just break that down in case you haven't listened to any of the other episodes that we talked
in the
about?
last 5 years of natural integrative functional medicine.
Yes, atopic IBS is a good one. I think we have a microscopic colitis episode. Okay, so H1, H2, right? H1 is going to be your Zyrtec, your
histamine 1 blockers.
H2 is going to be your Pepsid, your Zantac.
Yep.
Cromolyn sodium is going to be your topical, and then ketotifen is going to be your systemic mast cell stabilizer.
And I would do the food elimination with this.
Yeah. Why
not? Yes.
Ideally, unless the patient's completely unwilling to do it. So that's where I would start. Now, the caveat would be you don't want this going on forever because it can develop stenotic lesions. Mm-hmm. So if you need to use the budesonide, work with the GI and use the budesonide.
How are you monitoring treatment efficacy?
Clinically, usually, but I know symptoms. I would assume if someone is going to develop a stricture and they don't have one on the initial EGD, we will get some warning. They will have symptoms frequently, but if they're saying they're doing a lot better by removing cow's milk and taking cromolyn,
right,
I'm assuming they're not developing stenotic lesions.
I have mainly been seeing folks with heartburn.
Mm-hmm. I have been seeing folks, I think, with it. Now I'm recognizing that dysphagia.
Bloating. Yeah. I had a guy with just bloating, and this was and they diagnosed EOE, and it resolved going off of dairy and taking cromolyn.
Yeah.
I had a guy who was, every time he'd eat bread, he couldn't swallow it. Like he got so scared. He thought he could
totally seen that.
Treating SIBO completely reversed. He in a complete remission.
EOE.
He had EOE.
Oh, he did.
He had diagnosed EOE. His main symptom was he could not swallow bread.
So the SIBO was triggering the eosinophilic.
I believe that we use herbs exclusively, and I think it was a methane dominant SIBO. I need to look. We use herbs exclusively, and then really, now that I'm thinking about it in hindsight, probably what made the biggest difference is phase 2 when we went after the diet. You know, that diet that I use is like gluten-free, dairy-free, grain-free, sugar-free diet. Like, of course that helps EOE.
Yeah.
Like, that's like, pow, wow, I get it. Yeah. Great.
So I would say in general, of course, depending on what setting you're in, you can try a PPI, not great efficacy. Budesonide works better than PPIs, or you could try this other approach using mast cell stabilization, H1, H2 blockers, dietary changes for everyone.
And should we talk about herbal quercetin?
Yeah. So let's talk about what are you thinking? What's your big histamine stabilizers?
Well, I like quercetin.
Okay.
I would also wonder about diamine oxidase as an enzyme to break
DAO
down
hist.
Yeah, to break down histamine in the gut. Zinc carnosine, would that have any relevance?
I mean, I think
Maybe
if
in
there's
healing,
I think
right?
if there's stenosis, but high dose vitamin C is another one.
Yeah.
Polyphenols.
Yeah.
Like polyphenols work great for these patients because it's local, and especially if you can get it like a liquid.
Yeah.
I think that works great for these
Like
patients.
blueberry juice.
So what I have
like
patients do
blueberry
that
compote?
works really well is
Yeah.
I have them go to Costco or
Put
go
on
to their
your
grocery
pancakes.
store. I mean, kind of. I have them go to their grocery store and buy like all the frozen organic berries.
Yeah.
Put it in their slow cooker.
Yep.
And slow cook it for like a long time. Just let it consolidate for like 12 hours. Make a syrup. Leave that syrup in the freezer.
Oh,
I
sounds
have them
delicious.
put them
Yeah.
in ice cube trays.
Oh, okay. And then you have them just
You
melt
can,
it.
You can put it in your water during the day.
Oh, yeah,
Or
yeah.
you can warm it into a tea.
Yeah.
You can put it in your cocktails.
Yeah. I mean, that's a great idea.
Yeah, or mocktails.
Yeah. Yeah. And so
good
I'm
options.
using those for sure. DGL and just straight up licorice.
Yeah, I was wondering about like demulcents, like
Mhm.
soothing because it's irritated tissue.
Mhm.
So Althea, things
Yes.
that just calm. There's a ton
For
that we
sure.
use.
And then carminitis.
Yeah.
Like to keep things moving.
Yep.
Yeah, that's how I would treat it herbally.
Yeah. Cool.
All right.
Other questions? Should we recap? What did we learn?
Well, I learned that the main symptom isn't heartburn for
Mhm.
adults. So that's cool.
Could be a
Could be.
presentation, but
Yep,
not
yep,
the
yep.
most common.
Yep. And inflammation matters here. So there's a lot we can do with diet there. And testing, we need 4 biopsies on EGD?
Multiple biopsies.
Yeah,
And
multiple biopsies.
over 15 eosinophils per high powered field.
Yep. And then the conventional treatment sounds not that great.
Not effective.
But
Yep. But they're PPIs
Maybe
and
run-
budesonide.
run- yeah,
Budesonide, I think, works.
Yeah.
But
Well,
PPIs,
it
steroids
does work.
for everything.
Yeah.
Monitor fungal overgrowth.
yeah, and they
people.
work until they don't.
Elimination diet.
Uh-huh.
Got options there. Definitely do dairy.
And if the big 6, let me see if I remember the big 6: wheat, soy, dairy, eggs, shellfish, nuts.
You got it.
It was all
Ooh.
seafood though, not shellfish.
Oh,
right?
It depends which study. Don't ask me details. You're gonna have
Okay.
to sort that out with your patients with one of those
'Cause I
annoying
imagine
conversations.
Fish oil would be helpful.
because it's helpful for everything.
Yeah.
Yeah.
It's anti-inflammatory.
And then elemental diet also is quite effective, but borderline torture.
Yeah, and extensive.
All right.
Thanks,
Good
Dr.
recap.
Kapadia. That was
So
great.
great.
Bye, turds.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.